Right. So we're going to first go over lectures 12 and 13, the glomerular diseases. So we've got a bunch. These are available also, like if you want to look at, different resources. They are in first aid, pretty good. I know that like last year, you guys at the end of the year got the Kaplan like board review access. So I don't know if you still have it, but they've got like 2 videos on that. There's probably more. I can't. Oh, I know. Pathoma, they've got really good videos too. So if you want to like look at it or look at the book, that's a few resources. So I know I looked at it this summer studying. I thought Pathoma was good, and I thought that first aid did a pretty good job, but you need to know more details than are in Pathoma and first aid for your exam. Okay, and I'll try to highlight those as we go through. So here's our nephrons, and so we've got our collecting duct. Here's this is like our renal medulla, and here's our renal cortex. So you can see the distal convoluted tubules versus the more pink proximal. Right here is going to be an arteriole outline. Okay, so here's what the stuff is made out of. This is like back to histology. So our podocytes are going to be epithelial cells, and then the mesangial cells provide support. They're going to be phagocytic, contractile. They can proliferate and secrete mediators. So you can see podocytes, they have the little feet, and we're right here sitting on our basement membrane. And then that's our lumen. So we can see the podocytes. So here's our little feet sitting on our basement membrane. And so here's some morphic processes. Okay, here's another EM. So we can see fenestration right here in between our endothelial cells, and here's our blood. And then this is called our slit diaphragm between our foot processes on that basement membrane. Again, here's our bone space. Here's our membrane. Here is our endothelial cells, and here's our podocytes for their little feet and our fenestration. So looking inside out, we've got endothelial right here, basement membrane, and then epithelial, which is our podocyte. And then subepithelial is going to be under the podocytes or the epithelial. So sub, it's like a submarine. It's going to be under the epithelial, but above the basement membrane. So like right there. Okay, so what causes these glomerular diseases? A lot of them are due to immune system deposition. All of them are. And it'll either be type 2 or type 3 hypersensitivity. Type 2 is going to be antibodies. I think of like A, B is 2 letters. So that's how I remember that one. And then type 3, they're like floating, and the antibodies kind of float and stick to the glomerulus. Okay, so just looking at this again, type 1 is going to be like our IgE, like anaphylaxis allergies. Our type 2 is like our antibodies. So examples of that is going to be this Goodpasture syndrome, which we're going to talk about. And that has that production of IgG, IgM. So it's where our antibody binds to the antigen. Type 3 is going to be the deposition of complexes. So it's more complex than the antibody antigen thing. So it's, I don't know, bigger than 2. I think of it in first aid. There's a mnemonic. I just can't think of it right now. Look that up. But examples would be like lupus, and some of the glomerular nephritis, serum sickness, or arthritis reaction. I think that you probably talked about that in heme. And then cell mediated is type 4. We're going to have like activated T lymphocytes. So what I want you to do is for this exam, it's going to be really important. Like you may know in your head, okay, this is a type 1 problem. But if you don't know what it does, like you could get to the question and it's asking you all this stuff. Maybe it's not on this one. Okay, well, just in case, I think it might be derm instead that I'm thinking about. But just in case, like make sure that you know not only like, oh, this goes with type 2, but type 2 is like the antibody antigen on surface. Like type 3, okay, like let's say we're talking about lupus, that's going to be more systemic and it's going to be those complexes. So, and then they like to ask about type 4. So that's going to be that cell mediated, so T lymphocytes. I don't think that's important. Okay. So some descriptive words to remember this stuff and like understand what it means. We're going to have if terms that describe all the glomeruli, or if it's only one portion of the glomeruli. We've got diffuse and focal. So diffuse means that we have all glomeruli within the kidney that are involved. Focal means there's only a portion. So that's pretty easy, like if you think about it. But when we start going down to the other two, describing just the individual glomerulus is going to be kind of confusing. Okay, global. So now we're talking about one glomerulus, not all of them. So one glomerulus is going to involve the entire glomerulus. That's global. So it's like, think of like each glomerulus is like, I don't know, a planet. So global means it's like the whole planet, it's the whole globe. You know, there's multiple planets out there, but this one may only affect Earth. So it's only the globe, you know, or it could affect every planet. But so just kind of be aware of that. And then segmental is going to be only a part of each glomerulus. So here's an example. So we've got, like, let's pretend there's only 4 glomeruli in the entire kidney. And then this green shaded in is going to be our, is going to be what's affected. So if we look at this, so not all are affected. So first, how do we describe all of the glomeruli? That's going to be focal. So it's only 2 out of 4. And then we have to talk about, okay, what is, like, is it the entire glomeruli or is it just part of one? And we see that it's just part, so it's going to be segmental. So looking at this, it's focal and segmental. That's important later when we start looking at the stuff, and it might make it a little bit easier. So the lab technique is immunofluorescence. That's all we care about. Direct is the primary antibody, indirect, secondary. Okay. You're definitely 100% going to get these pictures, and you need to know if it's either granular or linear. So linear, you can see that it's, you know, they're all, you know, it's completely filled in. Granular, it's almost like little dot dots everywhere. There's little, like almost portions missing. So immune nephritis, which we'll talk about, is an example of granular. And on IM, and anti-GBM is going to be an example of linear. So don't worry, we'll talk about it. We'll see these pictures again. But, okay. More overview. We've already talked about nephritic versus nephrotic, but just to go over it again, nephritic is going to be a loss of some protein, but not a lot, so less than 3.5. But we're going to see inflammation in red blood cells. So I kind of think of like glomerular nephritis, and like the itis, the inflammation. Nephrotic is going to be protein loss. So you can see that the O's are both in nephrotic and protein. And it's a loss of greater than 3.5 grams a day. So I think of like, it's a glomerular issue. You know, I'm going to start losing protein in my urine, which is not good. So it's like if I think about like a screen, like I have a screen on my window, and all the flies stay out if I've got a brand new screen. So that's like protein. So like the little flies are like protein, and it's keeping them out of my house. But let's say I poke a bunch of holes in my brand new screen and flies start coming in. That's like protein coming in my house. So protein loss. So that's kind of what we're talking about with nephrotic syndrome. So we're going to see red blood cell casts with nephritic syndrome. Azotemia, which is going to be elevated BUN to creatinine ratio because we're going to be because it's going to be a high ammonia level because of the urea. We'll have hypertension, oliguria, which is like low urine output. You may see like protein in the urine, and that's okay as long as it's not above like 3+. Edema, and then an example that we have is RPGN, which is rapidly progressive glomerular nephritis. Okay, here's our azotemia again, elevated BUN and creatinine. Causes could be because of a decreased GFR, and then uremia is going to be azotemia with alteration systemically. Okay, that's too important. Nephrotic syndrome is going to be a loss of protein, like we had talked about, and so you're going to have like one of those proteins is going to be albumin. So you'll have hypoalbuminemia because you're going to be losing albumin in the urine, as well as like gamma globulin and antithrombin 3. You'll have hyperlipidemia and hypercholesterolemia because of the protein not being able to be like that mediator. So if there is protein loss, you could get renal vein thrombosis because of that increased lipid. Okay, here are our pictures of our glomerular nephritides. That's hard to say. And I tried to like include the pictures with some of them. These are from first aid. I didn't get through all of them. I didn't get the pictures with them, but at least there's 2. But we'll go through each of them. So I am just going to like skip these 2 charts, and that's for your understanding. But we're going to like go through each one. Okay. Let's start with our our nephritic syndromes. So a post-infectious glomerular nephritis, or rapid RPGN, which is one of the feared outcomes of one of the nephritic progression. And this patient is going to look really sick. They're going to have cold-colored urine, red blood cell cast, pyuria, so like pus in their urine. They'll be really sick. They'll be edematous, and they'll have renal failure. Okay. Usually with post-infectious glomerular nephritis, you're going to be presented with a patient that has had an infection like strep. And it's usually like, I mean, honestly, it's going to be like usually a kid. They've had, a sore throat. They even may have been treated for this sore throat, like let's say 2 weeks ago, and then they start, having dark colored urine. And you notice red blood cell cast. So this is what you should be thinking of. So they've got deposits on the glomerulus, and they're going to have a positive ASO titer. And so we're knowing, okay, there's been like this patient had strep, and now they're having like these antibodies. So anti-streptolysin. The immune complex, remember that is going to be hypersensitivity reaction 3. That is going to implant on the subendothelium, and then it's going to move to the subepithelium. So where these places are located in the kidney are very important to know. Most kids recover, and adults do too, but most likely you're going to see a kid. So had impetigo or pharyngitis, ASO is positive, and it's going to be subendothelium, subepithelium. Immunofluorescence is going to have granular deposits. So here's our granular, our dot dots, of IgG, IgM, and C3, and it's going to be in the mesangium and along the glomerular basement membrane. So on electron microscope, you're going to have subepithelial humps. So make sure that you know it's epithelial. And it's like these humps. So know this picture. Know it's granular. Know it's IgG, IgM, and C3 on the mesangium. No, it's after strep. And if we're looking on light microscopy, here's a normal, and here's our acute proliferative. So we can see that, like right here, we've got lots of white space. We can see, differences. Right here, there's no white space at all. In severe cases, and what we're going to talk about in like rapidly progressive glomerular nephritis, there's going to be this crescent shape. So you can see like a crescent formation. But basically know this one more. Lots of color. We don't see lots of space. So let's talk about rapidly progressive glomerular nephritis. It's a syndrome that has, that's immune mediated, and it has many etiologies. And there's 3 types. Type 1 usually gets called Goodpasture syndrome. So with Goodpasture syndrome, we're going to have hemoptysis, and we're also going to have like these kidney problems and nephritis. Okay. So on histology, it's going to be that crescent formation like we saw right here, and that's if it gets really bad. So I would remember this one more for our post-infectious glomerular nephritis, and I would remember the crescent for our rapidly progressive glomerular nephritis. There's going to be fibrin strands, focal necrosis, and then there's going to be endothelial proliferation and mesangial proliferation. Okay. All of them will have ruptures in the membrane. Type 2 is going to have immune complexes. So type 1, Goodpastures, is going to show linear deposition. This is where it gets hard. Type 2 is going to be immune complex. So it's going to have a granular deposition. And then type 3 is pauciimmune. Some pauciimmune vasculitides causing glomerular nephritis. I think you're probably getting vasculitis or vasculitides in cardio right now, if I'm remembering right. But I think that's on the third exam. Not totally sure, but I think. Examples of that would be microscopic polyangiitis or Wegener's, which, remember, microscopic polyangiitis is going to be MPO-ONCA, and Wegener's is the GPA, and that is PR3-ONCA. So, okay. Type 1, linear, which is good pastures. Type 2, granular. Okay, so RPGN, due to anti-GBM antibody, that is going to be, like, what you need to remember is that COL4A3 antigen. And remember, that is going to be our type 1. And then on immunofluorescence, again, linear deposits of that IgG, and then some C3. Okay, so now we're to nephrotic. So we did our 2 nephritis, or nephritic. So that's going to be, remember, RPGN, and remember it's crescent shape. And we've got either linear or granular on IF. Then our post-streptococcal, post-infectious glomerular nephritis, or post-streptococcal glomerular nephritis, same thing, just strep is the cause. We would have subepithelial humps on EM, it's granular, and then it's kind of on light microscopy, it's hypercellular, really pink. Okay, that's the review. So let's go to nephrotic. So we've got membranous nephropathy, minimal change disease, focal segmental glomerular nephritis, membroproliferative glomerular nephritis, and IgA nephropathy. So what's this patient look like? Well, it's a nephrotic syndrome. So we're going to have 3+ protein. We're going to be losing some immunoglobulins, so they'll be sick, clotting problems, high lipids. Okay, so let's look at our most common causes and then go from there. So something I would think about is that these, just like the other ones, I would sort of get a picture. So one of the things that I would do and think about is, okay, which one is either nephritic or nephrotic, and then which one's more common in kids versus adults. That can kind of help you maybe figure out them. And then most of these are going to have a disease associated with them. So I would know that as well. So that can help you. Because if they're oh, well, this patient has HIV versus Hep C, that can help distinguish which one it is for you to answer the question. Okay. So we said that kids can get the post-streptococcal glomerular nephritis. Adults can too, but it's more common in a kid because adults don't get strep as often. I know there's adults that do, but for the most part. So with nephrotic syndrome, the most common is going to be minimal change disease, and we're going to talk about that. And then for adults, usually there's systemic diseases like diabetes, amyloidosis, and lupus. So the most 2 common are going to be focal segmental glomerular sclerosis, and then membranous glomerulopathy. So clinical complications are going to be renal vein thrombosis. This is super important. Like I would start this. But renal vein thrombosis, vulnerability to infection, cardiovascular disease, and we will talk about the causes of these complications. But I will give you a hint. It's because of the protein. Well, we've already talked about it, I guess, because of that loss of protein. Okay. So we're going to start with membranous nephropathy, one of our big ones in adults. So, as you know already have found out, it's important for Nana know these antibodies are like the markers. So antibodies to PLA2R antigen and THSD7 antigen are important in membranous nephropathy. And the basement membrane becomes leaky due to immune response with our complement. So we have C5b through 9, which remember is our MAC. You can remember that from immunology. And we're not going to really see any neutrophils, macrophages, or platelets in our glomeruli. So what type of patient are we looking for? Males more than females, age 50 to 60, and it doesn't respond to steroids. One of the glomerulopathies do, but this is not the one. So my tutor last year said that the way she remembered this was you can't play at the, you can't play at the BQ or you'll get membranous nephropathy. Okay, let's look at let's look at light microscopy. So we've got basement membrane thickening. So here's normal. And we can see that the basement membrane, they just look really thick, like really bright, thick. We get closer, you can kind of see how it's like thin right here, and then this is super thick. Silver stains, which we're going to look at next, are going to have the spike and dome appearance. There's no hypercellularity like that we saw with our post-streptococcal. So here's that spike and dome appearance. So we see little spikes like that, and little domes. The spike and the little dome. The little projection. So this is silver stain, so we can see that it's like yellow in the background. Okay, imaging is going to also be granular, like some that we've seen. So this is kind of what it looks like. So you can see that it's like chop off, and then this is what's lighting up. On EM, there's going to be subepithelial deposits. So remember, subepithelial is going to be under a podocyte. And it's going to eventually cause that irregularly thickened membrane and effacement of the foot processes, so they're going to be flat. So we can kind of see this here. Okay, so that's membranous. Okay, minimal change disease. This is the one that is in kids. And I don't think the genetics are as important on this one. And they're going to have periorbital and peripheral edema. So you're gonna have you're gonna say a kid that was fine, and then now all of a sudden they've got like big swollen feet and swollen like under their eyes, around their eyes. And they're just losing protein because there's damage to the epithelium or podocyte. And this is the one that responds to steroids. So if you're given this and it says they were given steroids and improved, it's minimal change. If it says it's a kid and you know it's and you see 3+ protein, it's probably minimal change. So this is pretty cool. Light microscopy is going to be normal. Immunofluorescence is negative. But EM is going to have effacement of those foot processes. So I don't know why, but I think this is like my favorite for some reason. So we've got like, here's our foot processes, and then here, they're just like melted looking. It's like you had like candles and you just melted them all the way down. So minimal change. Here it is again. Foot process, flat, melted. Okay. Focal segmental glomerular sclerosis. So it's going to be a portion of them, and it's going to be a portion of the glomeruli, and it's going to be only like part of it. It's not going to be the entire glomeruli. Okay. So a hallmark of the disease is going to be that podocyte damage. It's not going to be like minimal change where they look melted. It's going to look a little different. So they're going to have hematuria, hypertension, and this is associated with heroin addicts. According to Robbins, it can be idiopathic. It can be associated with things like HIV. So, heroin addicts, IV drug users, HIV. Sickle cell disease could be it, but I would like no HIV more than anything. And then adaptive response is going to be compensatory, like getting larger, hypertension, and then injury leading to fibrosis. And then there's also like some weird inherited forms. Okay. APOL1 is going to be the gene. I would probably know that. And it's probably accelerated in SGS. I call it FIGS. I know it's not like, that doesn't even look right, but for some reason that's what I read when I read that. So I don't know. But, so if I say that, I mean focal segmental glomerular sclerosis. So sclerosis is going to be like fibrin deposition fibrosis. So hopefully maybe that can help. So it's that collagenous matrix deposition of the plasma proteins across the wall. So we're going to have hyalinosis, which we had talked about last week with some other diseases. And so hyaline, every time you see like hyaline, it means like super pink. And so here we go. We've got this pinkness everywhere. I know there's lots of pink. These are, I think, very hard. I think this is one of the harder things to know and differentiate between, like all these nephropathies. Okay, but we can do it. So immunofluorescence, IgM and C3 may be present, but normally it's not. And then we're going to have diffuse effacement of the foot processes, and I'll have on a microscope. So let's look. Well, I don't have a picture yet. Okay, sorry. HIV nephropathy. So we've talked about that that's important in focal segmental glomerular sclerosis. So is going to be the cause of the collapsing variant, and it's going to be a HIV associated nephropathy. So you can see like it's dark here. It's like collapsed looking. It looks terrible. So gotta remember that. Membranoproliferative glomerular nephritis, MPGN. It has two types. Again, we have another one that has multiple types. Type 1 is going to have classical and alternative complement pathways. And then type 2 is going to be the alternate. And the type 2 is the C3NES. And it can be nephrotic or nephritic, which is very confusing. I would just, I don't know. I would just kind of like sort of think of it as both. Even though it says itis at the end, so you're thinking, oh, it's only nephritis, but it can also be nephrotic. So don't get confused. So we have that stabilization of the alternate path by C3 NEF, which is NEF is nephritic factor in dense deposit disease. So type 2, its other name is dense deposit disease, and that's what you usually hear. So MPGN is going to have a lobular appearance from that proliferating mesangium and matrix, and then the thickened membrane is going to have that tram track appearance. So right here we have like lobules, it looks like. You can see like little lobes. If we get really close, it's got like almost like 2 lines with a little track. Okay, so type 1 is our subendothelial below the endothelium. Deposits, which are going to be immune complex mechanism. Type 2 is our dense deposit disease. It's in the lamina densa of the membrane. It's going to be irregular ribbon-like. And it's going to have that C3, and remember it's that C3 nephritic factor NEF. And it can form mesangial ring. So here's type 1 and type 2. So remember, we've got subendothelial deposits on our type 1. So we can see that the dense deposit right here, this like dark stuff, in the basement membrane in the mesangium. Dense deposit disease is going to have dense homogeneous deposits in the basement membrane that are be kind of ribbon-like. So see, it kind of looks like a ribbon. Okay, IgA nephropathy. We've got IgA in the mesangium. It's going to be polymetric and glycosylated. So it's going to be different than regular IgA, basically. I sort of like this one too because it looks different. So we've seen linear, that's kind of like sort of like ribbons. Granular is going to be like dots, and then IgA kind of, I don't know, just has a different appearance. I think it kind of, like maybe fire or something. You can see these little, lights up better here. And on light microscopy is going to have mesangial proliferative. So we can see it's like super dark right here. You may have to like almost flashcard some of these pictures and like really try to get them in your brain because I know they're really hard. Know where they're located. Know the population. Is it kid? Is it adult? Do they have HIV? Do they have like something going on? Know the light microscopy, the immunofluorescence, and electron microscopy. I know that's a lot. And it's like one lecture. So get it. Okay. Alport syndrome. Okay, I also like this one. And the reason why I like this one is it has my favorite mnemonic in the entire world. And it was recently, I was so excited. Like, I really wanted it to be on the Comlex. Didn't see it. But I did have it on my shelf exam. So I was excited. Anyways, it can't see, can't pee, can't hear. hear a B. That's how you remember it. So can't see, deafness. It's due to, can't see. I'm going crazy. Eye disorders. So that would be like early cataract. Can't pee. I've got hematuria. And then can't hear a B. It's going to be deafness. It's going to have that Col 4A5, Col 4A3. It's X-linked. And it's type 4 collagen, which is very important in the kidney, eye, and the cochlea. So unlike microscopy, it's going to be normal, and then it's going to look more like focal segmental. Immunofluorescence, normal. And then, I don't know, I just think of somebody like can't see, can't pee, can't hear a B while I basket weave. Like that basket weave appearance. So it's kind of hard to see, I think, but if we kind of look at this, we go, so it's got that. Basket weave one. Thin basement membrane lesions, which is also called benign familial hematuria. It's similar to Alport in the type of collagen. Like literally they have like thin basement membranes. And it's inherited. And they have hematuria. So who knows if that'll show up. Diabetic nephropathy. I would say this is important because there's lots of diabetics out there. So common lesions are glomerular, vascular, pyelonephritis with papillary necrosis is common, and it's going to affect the afferent and efferent arterioles. It's also going to have that pink stuff, pyelinosis. And a way of like knowing, like you may have heard, probably most of you know what a hemoglobin A1C is. But basically, we've got lots of sugar and it's attaching to the hemoglobin. So a high hemoglobin A1C has lots of sugar attaching to the hemoglobin. And the sugars start, think about it. Like you get something on your hand. You ate a candy bar. And, or you ate, let's say, hard candy. And it sort of melted a little bit, like maybe a Jolly Rancher. And your hands are really sticky and it starts sticking to stuff. And so that's how like this hemoglobin is with all the sugar on it. So it's starting sticking to things like your eyes, your nerves, your kidneys. And so that's why we have early microalbuminuria. And that's why like they have peripheral nephropathy or, or it affects their retinas. So that's just the way to think about it. We've got capillary basement membrane thickening, as well as sclerosis. It's going to increase in the mesangial matrix. It's going to be PAS positive. What you probably need to remember is Kimmel-Wilson disease. And so let's look at pictures. So you see like big pink pyelinosis. And we see basement membrane thickening. Okay, let's look at the lupus. Lupus is going to be immune complexes. And the most common cause of death in lupus is going to be renal failure or infection. Our immunofluorescence is granular. So we've got 6 patterns, and I've got like a star. Because I think that she said like knows the patterns, but I really don't remember it being like super important. But don't hold me on So, oh, here we go. So I guess you do need to know them. But here's all of them like listed out. So she doesn't go through, I don't think, all of them, but type 1 and 2, or class 1 and 2, are going to be mesangial cell proliferation and increase in the matrix with immune deposition. So we can see this right here, but there's no involvement of the capillaries. Okay, class 3 and 4 is going to be our focal proliferative or diffuse proliferative glomerulonephritis or nephropathy. So remember focal, less than 50%, diffuse, it's going to be most of them. And it's going to be the most severe form because it's affecting pretty much all of them. So let's look at focal proliferative. This looks normal. And then can you see how this is like really bright, busy? Global proliferative, affecting everything. Class 5 is going to be membranous, and it's going to be diffuse thickening of the capillary walls. So remember, 1 and 2 didn't affect the capillaries, but class 5 does. And it's going to have subepithelial deposits. Okay, all are going to show mesangial deposition. Class 5 is going to be primarily subepi. Class 3 and 4 are going to be subendo. And wire looping is going to be super important. So right here, we can take off my picture. Right here, can you see how it looks kind of like wire loop? So we'll undo. There we go. All right. Wegener's. So good pasture is going to be hemoptysis plus kidney involvement. Wegener's is going to be different. It's going to be the upper and lower respiratory tract plus the kidneys. So it's going to have nasal involvement like sinusitis. The bridge of the nose would be depressed. So it's like a saddle nose. Sometimes you hear them talk about it that way. They're going to have like, you know, a chest cold, cough symptoms like pneumonia symptoms, and then kidney issues. Okay, so microscopic polyangiitis is MPO-ONCA, Wegener's is PRC-ONCA. Other types is going to be like bacterial endocarditis associated glomerulonephritis or amyloidosis, which will have beta pleated sheets. So let's look at that. The most common type is light chain. I think light chain might be pretty important. And there's two types. There's AL and AA. AL would be like multiple myeloma. AA is in inflammatory states, and then there's also a familial form. So here's our amyloidosis that you can see. Remember, always important: Congo red stain, apple green, birefringent with polarized light microscopy. So here's our amyloid deposition. Here's our apple green birefringent of amyloid appearance with Congo red stain. And so we can also see it depositing here. Okay. Review. I know it was a lot. So our NCD info FSGS is going to be podocyte, so minimal change, focal segmental, podocyte effacement. More so with minimal change, like it looks real flat. Membranous is going to NPGN is going to be deposition of immune complexes. Diabetic and amyloid is going to be systemic. And then IgA is mesangial. Okay, we got through that. So I'm going to switch to the next one. All right. So now renal tumors 1 and 2. Renal tumors 1. So there could be renal agenesis. So it's going to be a congenital absence of a kidney or both kidneys. So we can see in this picture there's only one kidney that's showing up on the left. It's associated with our trisomy 7, 10, 21, 22, as well as Turner syndrome, and that's unilateral. If it's bilateral, if we have no kidneys, there's no way to filter our blood or our urine, so that's going to be fatal, and that's called Potter syndrome. Potter syndrome is going to be, you're going to talk a whole lot about it when you get to the OBGYN class. So you're going to have low set ears, like a beaten nose. Basically, they're like pressed against mom's stomach with like nothing, no like amniotic fluid because they're not peeing. So there's going to be prominent folds, pulmonary hyperplasia. It causes respiratory failure. Their limbs are going to look abnormal because they're being pushed up against the uterus, like one side. So there's nothing to like swim in. That's not as important right now. Renal hypoplasia will have a small kidney. So there's going to be less nephron, but it's going to have normal architecture, but with some dysplasia. And so what happened is in the first trimester, development stopped, and low amniotic fluid will be present. The normal kidney may become bigger to compensate. Ectopic kidney is going to be at abnormal location because in the cephalon migration, where we had our kidneys that start down here and then they migrate upward, something stopped it. It's usually not really asymptomatic. They're going to have a normal abdomen exam. But like if there's a traumatic injury, it could harm the kidney because it's not in the right place. Horseshoe kidney, our kidney poles are going to be connected to each other at the lower pole. If it's a complete fusion, it kind of looks like a pancake. So we can see, looks like a horseshoe. And then the inferior poles touch and fuse together. The most common problem is a UTI. When they're kids, in adulthood, it can lead to renal cell carcinoma. Cystic diseases. So the most common and the one that people think about is polycystic kidney disease. There's going to be autosomal dominant, and then there's going to also be autosomal recessive. Okay. So the autosomal dominant, the patient is going to be complain of possibly abdominal flank pain, and then it'll be an adult. So I think of AD, autosomal dominant, as adult. And that's how I memorize it, and it's like really easy to know it's autosomal dominant. But you have to know that, since there's also an autosomal recessive. Hypertension is going to be when they're an adult, because like the RAS system is not working well. There also may be cystic masses in other places like the liver. And they love to ask this question. You see a patient with a bunch of cysts everywhere, and what do you need to screen them? And they've got really high blood pressure, like what do you need to screen them for? And it would be a berry aneurysm, intracranial aneurysm. Okay. So PKD1 and 2 are going to be the genetics, and don't just memorize PKD1 and 2 like I did. Know that it stands for polycystin 1 and 2. I just know it's PKD1 and 2. If there's one cyst on a kidney, that's normal. You can get cysts anywhere in your body. But if it's completely cyst, I mean, there's nothing that kidney is like almost able to do. So you can see it on microscopy. You don't really care about the tab. It's not colored. Okay, autosomal recessive is a product of fibrocystin. It's PKHP1. So this is not going to be an adult that's going to be presenting, but it's a child. They're going to have bilateral kidney disease at birth, and they're going to have low amniotic fluid, causing not a lot of movement. And a presentation may be Potter syndrome. And with Potter syndrome, mortality is usually from a pulmonary problem. So looking at this, we've got, so before, it's not even really cystic. It doesn't even look cystic like, like the outside looks, fairly normal compared to our autosomal dominant kidney. But I think of these as kind of like tubes almost. I think it looks like a bunch of tubes in there. So here's, and it's fibrotic. And there's also going to be hepatic fibrosis. Okay, here's a comparison of the two that you can look at later. Okay, this is a hard word. Nephronopathesis. Not sure if that's right. MPHP1 and 2. And in the juvenile, it's corticomedullary cyst, atrophy, and interstitial fibrosis. In a kid, it's going to have polyuria, polydipsia with normal blood pressure, leading to chronic renal failure in 5 to 10 years. So we can see these cysts at the corticomedullary junction with thick basement membrane. So the outside looks normal. Just know this is another cystic kidney disease. So features of this are going to be normal to small kidneys with cyst at the corticomedullary junction. Make sure you know that. And then thick basement membrane with a PAS stain with fibrosis and inflammation. So we can see this thickness. Here's our inflammation. And here's our fibrosis. Okay, medullary kidney disease or cystic kidney disease is also autosomal dominant interstitial kidney disease. So medullary sponge kidney, they literally look like sponges, I think. Like if you looked at a sponge, it looks pretty much just like that. So I would make sure I know this one. It's got cystic dilations of the collecting ducts. And usually it's asymptomatic, but they could have stones or hematuria. Like the size of the kidneys are going to be really normal. Medullary renal dysplasia is going to be anomaly caused by metanephric differentiation. If it's bilateral, Potter syndrome. Unilateral, no problem. So the thing, I think this one's probably pretty important too. So it kind of would like make you think of maybe the autosomal dominant polycystic kidney disease, but this is, I would think it like more in kids, and then also you're going to notice like blue cartilage. That's not normal. And AVPKD. So there's the cartilage. You can see these like that glassy appearance that cartilage has. Really big cyst with flattened cuboid epithelium. So that bluish tinge, remember, cartilage, medullary renal dysplasia. Big cyst. Dialysis can cause a cystic disease. More than 4 cysts involving both kidneys is what qualifies for this. And the cysts are going to contain oxalate crystals. If they're on dialysis and you see 1 or 2, then it's fine. It's normal. Here's a simple cyst, normal, occurs with aging. 1 cyst, it's not everywhere, or a few, but it's not too bad. You don't really do anything, or you can drain it. There's all of them, what they look like, and you can differentiate. Okay, renal tumors 2. Renal adenoma. So adenoma is going to be a benign tumor coming from glandular structures in the epithelial tissue. They're going to be well circumscribed and unencapsulated tumors, sonoma bodies, exoma cells, and no invasion. So looking at our path, there's small cuboidal cells. Here's our sonoma bodies. And here's some exanthomas. It's not invading, so really dark. Angiomyolipoma. So angio, blood vessels. Myo, muscle. Lipoma, adipose. So it's associated with tuberosclerosis and has genetic components, and it can cause a retroperitoneal hemorrhage. So you're going to see spindle cells, adipose tissue, and then thickened blood vessels. So really look for all 3 things. Look for blood vessel, like spindle cells, and then fat cells, and you've got this one. Here we are again. Here's our spindle cells. Here's our really thick wall blood vessel, and here's our fat. And it expresses HMB45. Okay, renal oncocytoma is going to have that stellate scar. It's going to be uniform and round with that central nucleus. So here's our scar, the yellowish scar. It's uniform, round, small cells with central nucleus. It's negative for the Hell's colloidal iron stain, and then it's got scattered or negative CK7. And you can see how it doesn't invade. Okay, renal cell carcinoma. Risk factors are going to be tobacco, obesity, and hypertension. And there's going to be 4 genetic disorders that are going to be associated with renal cell carcinoma. Things that you think about with renal cell is going to be a flank mass and hematuria, but no pain. von Hippel-Lindau syndrome are going to be many fluid-filled cysts all over the body. So both copies have to be mutated. And then hemangioblastoma is going to have that higher risk for that renal cell carcinoma. Theo and pancreatic neuroendocrine tumor. Papillary renal carcinoma is going to be autosomal dominant. It's going to have that MET proto-oncogene receptor tyrosine kinase, and it can be seen in papillary renal cell carcinoma. Vertog-Dube syndrome is going to be a skin lesion, lung lesion, and renal tumor. It is going to be a chromophobe that doesn't stain easily. Hereditary leiomyomatosis and renal cell cancer syndrome is going to be autosomal dominant. And there's uterine lesions, renal tumors, and it's not really has a poor prognosis. Some of these I don't think are like as important like those. General factors: male, tobacco, hypertension. So triad, flank pain. This is like pretty rare. They actually have pain, but anyways, flank pain, hematuria, flank mass. It's more common that they don't have pain, but it might say pain on the test. So smoking and VHL increases the risk for clear cell type renal cell carcinoma. And they're going to be arranged in nests with intervening blood vessels. And they express cytokeratin and vitamin. Papillary type, remember, has that MET proto-oncogene, and it's going to have foamy macrophages. So we can kind of see how it looks foamy. I know it's like everyone's favorite term from histo. So look at this clear cell. I mean, they're like really clear, and their nucleus is over to the side. It's not in the center. These foamy pink. Chromophobe type renal cell carcinoma is going to be associated with Vertog-Dube syndrome. And it's going to be less aggressive, and it's going to be positive for that colloidal iron stain, which is going to look blue. So remember we had said before that the renal oncocytoma is going to be negative for Hale's colloidal iron and CK7, but this one, our chromophobe type renal cell carcinoma, is positive and it turns blue. Okay, XP11 translocation is going to require FISH or PCR to diagnose, and it's a pretty aggressive clinical course. Bellini cell duct renal cell carcinoma is going to be poorly circumscribed tumor metastasis at its presentation. Okay, urethral carcinoma of the renal pelvis. Patient is a coal miner. So risk factors are coal, asphalt, petrochemicals, tar. You know, tobacco is a problem with a bunch of this stuff, but so I would think like coal, asphalt, tar are important. It's multifocal, could be in the ureter or bladder, and there's going to be differentiation with or without the papillary pores. Back to this one, like looking at this Bellini, it's got they're kind of linear. I just thought about that to help you differentiate. There's lots of purple. It's not anywhere except the renal pelvis. It's not in the cortex. Okay, Wilms tumor is going to be the most common pediatric renal tumor involving both kidneys. It's usually pediatric, and it's going to spread into the soft tissue. Okay, so here are some tumors. There's epithelial elements, fibroblastoma, and here's our blastemal. So let's look at Wilms tumor. So this is Wilms tumor. So Weiger syndrome goes along with this. It's got PAX6, WT1. Weiger stands for Wilms. Anardria, genitourinary malformations, and then intellectual disability. Dense-Drash is going to be WT1, just like Weiger. It's going to have that triad of congenital nephropathy, Wilms tumor, and intersex disorder. Beckwith-Weitzman is going to be IGF2, and it's going to have congenital exophthalmos, macroglossia, big tongue, big person, gigantism, and most of these have that intellectual disability. Nephrogenic rest are going to be that focal, persistent embryonal cells after a period of normal nephrogenesis, which is going to be a precursor of Wilms. I don't think this one's as important as some of the other ones. So make sure that you know the Wilms and you know the syndromes that go with it. I think the easiest one is like Weiger because it spells it for you. Make sure you know the difference between the cystic kidney diseases. There's a few of them. And I know that you go over it with Dr. Wong, and then you also go over it with Dr. Luttrell. So some repeat. Coal miner, only in the renal pelvis. Chromophobe type is going to be same blue, associated with Burt-Hogg syndrome. Blue Burt. Clear cell, associated with smoking and VHL disease, looks clear. Papillary type is more foamy. Angiomyolipoma is going to be blood muscle fat. And then we kind of talked about those. Okay. So let us get to the next one.